We know that diabetes mellitus and hypertension are two common, very serious disorders, and one must know how to manage them properly because there are common misconceptions about managing diabetes as well as hypertension. So, this little slide presentation is all about what is right and what is not right. So, first thing, HbA1c, what it really shows. HbA1c reflects average blood glucose over last 8 to 12 weeks. Best use is in monitoring diabetic control when the patient is already on diabetic medicine, anti-diabetic medicine. We want to know whether he is well controlled or not. So that is when it is most useful to assess the response to treatment, and it helps to predict the long-term complications. That is what's its real use. But it's not ideal as a standalone diagnostic test in every patient. Particularly, we should not diagnose diabetes in a non diabetic patient as such. Rather, we should restrict this test only for the follow up. Now, HbA1c, when it can mislead, it may be falsely high or falsely low. Falsely low HbA1c occurs in any hemolytic condition whenever there is blood loss or in transfusion. Similarly, in chronic kidney disease, it is falsely low. And similarly, it can be falsely high HbA1c in iron deficiency anemia, some hemoglobinopathies. So that is most important that one should interpret it in the setting of the patient. Now the next thing is about hypertension. Generally, when we see this high blood pressure, the patient is already in panic, and so is doctor usually. The knee-jerk reaction is to put caputin under the tongue. That is what is not right, because sudden drop in blood pressure can actually precipitate cerebral cerebral mismatch, cerebral blood flow mismatch, because low blood pressure would certainly give rise to sudden low blood pressure will give rise to ischemia to the brain, and one may end up actually in what we call uh, paralysis, or actually that may become counterproductive. So one should understand that high blood pressure, is it in the setting of urgency or is it emergency? Not all high blood pressure needs instant lowering. As I mentioned, hypertensive urgency is when no organ damage, one has to treat it with oral medication and wait for 24 to 48 hours. Let the blood pressure slide down rather than drop down. If the blood pressure drops down, so will be your patient like this, because the blood flow to brain becomes not enough and causes brain ischemia and hence a stroke. The very thing which we want to prevent and the very thing which we are very much concerned about. Now, hypertensive emergencies are when along with it there is LVF, there is unstable angina, there is a stroke in evolution, or stuttering hemiplegia as we call it. So in such situation, rather than putting caputin under the tongue, better it is to send the patient to the hospital. The patient must be in ICU monitoring, and often IV drug like nitroprusside would be needed. So that is a message about these two common disorders commonly mismanaged. So I hope this slide helps. Thank you.